Good afternoon. This is the House Appropriations Committee. It's Tuesday, April 7th, 2026. It's just after 2 p.m. and we are going to learn a little bit more about something we've spent a lot of money on over the last couple of years, extraordinary financial relief for nursing homes. And we have folks from Diva and Dale to talk to us about it. I know you all gave a presentation to Human Services last week, and we appreciate you making the time to come and talk to us as well, because it's something that we've talked about a lot in this committee and would like to understand better. So I don't know who is starting, but I'll leave it to you two to take it away for us.
Yep, I'll be taking it away. So I am Jamie Mooney. I'm the Director of the Division of Rate Setting from Department of Vermont Health Access. I'm going to start by going over the table that I provided, but I'm going to share my screen if everyone's okay.
That would be great to share the screen so people can. This should be on our committee page. This is the other one.
Okay. Is everyone able to see my screen?
Yeah, you could make it a little bigger maybe, but we're okay if not.
Okay. Perfect. So this data that I'm going to be going over covers 33 Medicaid participating skilled nursing facilities. We also do have the 3 additional facilities in Vermont that do not accept Medicaid and are therefore not included in the Medicaid data, but we did include them where we could here. So that's the Arbors Nursing Home, Merton's Home, and Wake Robin Linden Nursing Home.
So the 3 non-Medicaid are the Arbors and Wake Robin, and who else?
And Merton's.
Merton's. Where's that?
Woodstock?
Woodstock?
Going back a number of years. I don't know. I'm going to play trivia, so I want to find out.
You're practicing.
Yeah.
Okay. All right. Thank you.
Yep, absolutely. So this first tab is just the table of contents that ties the legislative section numbers to the tabs that I have here. So that's all this is. But the next tab is the ownership type and average length of stay. So this tab lists all 3 Medicaid participating nursing homes. It also includes the 3 nursing homes that don't participate in Medicaid. It includes their ownership type, the average length of stay, short stay, which is under the 90 days, and long stay over the 90 days. So the breakdown of the ownership is we have 23 for-profit nursing homes. We have 6 nonprofit nursing homes. We have 3 nonprofit hospital-related nursing homes, and then the 1 state facility as well.
Hang on 1 second.
Yeah.
We don't have all those.
Yeah.
Autumn.
You have to scroll down to the next page.
Oh, we didn't get all these pieces of paper that have been printed out, Autumn. I don't know what. We just have the type of control and not the average length. Right, it doesn't show it on that piece of paper.
This is the additional, this is under the additional. Yeah,
I just received what was on the House Human Services page.
there were two links, one to this report and then the different.
Okay,
This report.
right. It's just, maybe it just didn't print out right. That's what I'm thinking.
Oh,
Well, there was the report and there was what's called the additional report. That's what she's showing us now.
When it printed out correctly, I just posted the report that.
Oh, I see. So we don't actually have, where did you find? Sorry, we're just trying to get ourselves oriented here because I'm not seeing.
On our document page, it says there's 2 documents listed, additional reporting.
I have the other one that has this, but the second page only has type of control. It doesn't have length of stays or days.
correct.
So maybe we need another document. Maybe you could resend it with all of this that you're showing us. So I'm glad you have it on the screen because we don't have that information on this chart.
I click on the link, I can't make that open.
Yeah. Okay, so if you can send it later, that would be great. That has this, all of this on it.
Absolutely. Yep,
Thank you.
absolutely.
Okay. So continue. Sorry about that.
Oh, no, you're fine. So to go over a little bit of the length of stay, so short stay under the 90 days, we have a range from 27 days to 56, and most facilities are clustering between 35 and 40 days. And then the long stay over the 90 days, we have a range of 167 days to 329 days. what we did find is that the facilities that had the long average stays tend to be the facilities that have special rates with the division of rate setting. So we have Crescent Manor with the Huntington's unit. We have Mission Care, who takes a lot of behavioral rates. And we have Maple Lane, who also takes a lot of behavioral rates.
A lot of what, behavioral things?
Behavioral rates, yeah. We have a section 14.2 in our rules that is for behavioral rates. So if they're hard to place at a nursing facility and they need more one-on-one care, we have a rate that would incentivize the facility to take the harder to place residents.
So can these nursing homes that accept Medicaid, can they turn down people that they don't want to take?
Yeah, I would defer to Dale on that one, but I believe so.
Okay.
Yes. Hi, Angela Smith-Jang, Deputy Commissioner of Dale, for the record. Yes, nursing homes do have the option to deny an admission to, it's their choice who they accept, who they don't. They have to be able to meet the level of care that that individual needs to be able to accept them.
And do you have any regulations about helping them to? I've heard stories from people I know about whose relatives have not been able to get in because they have multiple medications maybe, and somebody they don't want to give them those medications. You know, maybe wound care, I don't. What are the reasons they say no?
Yeah, there could be many reasons that they're not able to meet the level of care that someone needs. It often has to do with, do they have the staffing to meet that person's need, especially if that person needs more individualized staffing or specialized training for someone. I haven't heard reasons related to medication use or wound care. So that's a different reason. But this is why we do have special rates to incentivize nursing homes to take individuals who need more care so that they can have the training and the staffing needed to be able to do that.
And are there a lot of empty beds? I don't know who answers that. I don't know who to these questions though, so.
I did pull up the data today from the bed board, which is self-reported data from the nursing homes.
Yeah.
As of today, nursing homes have reported statewide approximately 250 unoccupied beds, which is about 9% available. Some of those are not necessarily available beds today for someone to be admitted to. There's a number of reasons why, if it might be a male bed, it might be a rehab bed, those types of things. But approximately 2,472 beds are occupied now. So we're at about 88% occupancy as of right now.
Wait.
So say there was some patients, say there's a behavioral issue with perceived danger to the personnel. That might be a reason why they do not take that. Yes.
That could be a reason.
Doesn't sound like it's the only behavioral reason though.
But I'm just picking on this one for the moment. And they don't have anywhere else to go, so they go back to the hospital, to the nurse, back to the emergency rooms and the hospitals.
Well, this is again why we have worked with nursing homes to have that incentive rate for taking folks who might be more difficult to admit. Mission Care certainly has admitted many people with high behavioral health needs. If someone is extremely violent, that is, they have to, it's a congregate care setting, right? They're taking care of the entire population. So they have to think about safety as part of the equation as well.
I'm just trying to get to our hospitals have been trouble with having to deal with people that are not true emergencies, but they're this kind of thing. And so, in asking the question is, are there alternatives? Is there any alternative? Is that one of the reasons? Is that a primary reason why we have problems in our hospital system? I'm trying to get to.
I'm not sure I can speak to whether it's the primary reason. for a hospital to
Understood.
have a challenge. I do know, we do track the number of people who are post-acute in a hospital waiting for some sort of, a discharge of some kind. And it's 68 statewide as of today.
68.
68 are in hospital waiting to be placed somewhere.
Right, not
Okay.
necessarily a nursing home.
Yeah.
But waiting for discharge to go somewhere.
Okay,
Okay.
great. Yeah, thank you.
That's good, thanks.
So Jamie, we interrupted you. Continue.
Absolutely. Is there any other questions on this page before I jump to the next tab?
So there's a lot of for-profits. Are some of these owned by the same company?
Yes, we do have some. So that will also get into the next tab here where we do have some that, Genesis owns a couple of the facilities.
Yeah.
Stellar Health Group owns a few, so does Alair. So we do have a few that own 2 or more facilities.
Okay.
And for-profit could mean a large company. It could also mean a private, a local owner as well.
Right. And are some of these also private equity owned?
That is something that the Division of Rate Setting has not necessarily tracked in detail to know which ones have private equity, but yes, a few, most of them probably do, but I don't know that off the top of my head.
Okay. So I'm told Department of Health probably has that information, but they
No,
don't.
it was part of the bill.
Oh, that
That
start tracking.
was passed this year, yeah.
Okay,
I mean, out of the house.
okay.
Mhm.
All right, continue. Thank you.
Yep, absolutely. So this next tab goes over the ownership. So it has the contact information. We have the facility, the chain name or management company name, the owner's name, and then the owning company contacts or board of directors. We did not include email addresses and phone numbers, but we do have this note here that says contact information for each facility can be provided upon request. So that is what this tab is showing. The ownership. Does anyone have questions on this one?
I don't think so. I'm not seeing any.
Okay. So the next tab that I have is the payer mix. So this shows each facility's revenue breakdown by payer type. Vermont Medicaid, out-of-state Medicaid, self-pay, Medicare, other managed care, commercial insurance, hospice, VA, and other. So 26 out of 33 of our Medicaid participating nursing homes, which is about 79%, derive 60% or more from Vermont Medicaid.
Say that number again, 26%?
26 of 33 of our facilities, so that would be
Okay.
79% of our facilities derive
Yeah.
60% or more of revenue from Vermont Medicaid.
Okay. And go ahead, Dave.
Is there, and this may be a Dale question, is there any correlation between payment rates and quality and Medicaid utilization, those having high utilization and quality?
I don't have that information off the top of my head. We can follow up with you on that.
I don't know if licensing and protection, if you
Yeah,
do it by deficiencies or whatnot, I'd be interested in that.
the Medicaid utilization and correlation with quality and
Payment
payment
rates.
rates and quality.
And then also, if I could just continue a little bit, acuity scores, and that's the severity of illness, but case mix acuity scores and quality. So that would show those, potentially those with higher quality needs, what they're being paid, and also if there's a difference in quality outcomes. However you folks measure quality. Thank you.
Absolutely. So the other area is Medicare, which typically reimburses at higher rates, and this is ranging from 0 to 22%. We do have that the higher Medicare shares provide some revenue flexibility within the nursing homes.
Have you seen any trends in this over the years? Are there more people, higher percentage of people on Medicaid coming to the nursing homes, or what are you seeing in terms of trend lines?
Rate setting has not necessarily looked at the trend lines, but that is something I can always get back to you on as well.
So you don't compare normally to previous years, or?
We look at this each month, but we don't go in detail to figure out what the utilization of Medicaid has been over a period of time. We just haven't looked at that recently,
Okay.
but we have the data.
Okay. Is there some other area that does that on a regular basis? No. I'm not seeing it, yes. Okay, thank you.
Okay. Were there any other questions on the payer mix before jumping to contract staff?
Yeah, one more, yep.
I'm just going back to some of Dave's questions. Other than, I assume that you have inspections or those sort of things that were as a basis for judging quality. Do you have any other metrics that you do in order to assess quality of care besides, audit reviews or inspection reviews?
Right. So it is the Division of Licensing and Protection, the Survey and Certification Unit that oversees the quality at nursing homes on behalf of CMS, right? And so the primary metric is the survey results, right? So deficiencies or otherwise. One and then there's like a quality rating for each nursing home as well. One area that we are also looking at, because it has increased recently, are incidents of immediate jeopardy. When there's it's called immediate jeopardy, but it means if there's immediate risk of harm of an individual when there's a survey visit, and those have increased in 2025 compared to previous years. And that's something we're taking a close look at to understand what may be impacting or causing a higher rate of immediate jeopardy incidents. Usually when that happens, the nursing home immediately puts in a corrective action plan, and there's a quick follow-up process to rectify the situation.
So dementia patients, any change in proportion, or are they spread evenly through the system, or are they concentrated at certain facilities? Is there any changes there?
There are people living with dementia in almost every nursing home across the state. There are some nursing homes that have certified dementia care units, a designated unit for people with dementia, but people with dementia may be in every nursing home across all of them.
If you could, I'd like to know if you could, I wouldn't expect you to have it today, but if you could find out what percent of admissions over the last year, pick a period of time, come from home, and what percent come from hospitals? And it would be great to have that by region. And what's behind that question is I'm using home-based admissions, and I could be wrong to do this, but as an indicator of strength of the Choices for Care community-based program, behind an assumption that if in Wyndham, I'm just picking, Wyndham County has a high number of home-based, is that indicative that their home-based care system needs to be strengthened, or something is going on would allow you to look there? It could be that the people in the home-based system are more frail and more ill, and they've reached the point where the nursing home placement is appropriate, but what allows just looking to get a sense of that. And then finally, if there's been an impact on admissions due to the distribution of EFR assistance. So if two nursing homes in the southern quadrant of the state are getting enhanced financial relief, and typically when that happens, their enrollment is down, their occupancy rates start to get lower. And if people don't have that resource to go to, it could be, what becomes of that? Do we know what that impact is? That could have an impact on our cost assumptions. We might think, boy, it's really expensive to do EFR assistance, but if you don't do it, maybe hospital admissions go up.
Yeah.
If you could help us with any of that kind of thought.
Yes,
Thank you.
we can follow up with that. One thing, I think we have seen facilities receive EFR who have different levels of occupancy, but it certainly could impact it over time. And I was also thinking about the percent of admissions from home versus hospital and trying to understand the strength of the system overall from that. It would also be good to know how long were they on choices for care living at home
Yes.
before seeking a hospital or a nursing home placement might be helpful to know.
But also, I'm sorry,
Okay.
tracking the discharges from the nursing home. How many discharges go to the hospital? And it might be totally appropriate. It could be that the nursing home doesn't have it may not do IVs, et cetera, a reason, and trying to track hospital admission rates because there's a penalty if it's too high. Thank you.
Right, absolutely.
Lynn?
Yeah, I'm sort of curious with what David's suggesting. My understanding is that, well, first of all, you could have people who've been at home and then under choices for care or not,
Right.
but then are admitted to the hospital because they actually have a situation that requires hospital care.
Right.
And then from there, that is determined they should go to a nursing home.
Right.
The other thing that contributes to this is that if you're in the hospital for a certain number of days, you qualify for Medicare once you enter the nursing home. So there's an incentive to put you in the hospital so you can qualify for that. Is that still true?
I'm not sure. I don't have the answer to that question.
3-day prior hospital stay.
Yeah,
Right.
I think it's still in place, but that's what
Yeah.
it is. Then you can access your Medicare for up to 21 days.
Yeah, and then you
Yeah.
go to Medicaid.
Yeah.
That would skew it.
Go ahead, Wayne.
Again, following up on Dave's, some of the flow through the system. I mean, is data being collected so that you know how many, it's one thing to know how many people are in at any particular day.
Right.
Or how do they flow through the system? How many ins and outs, through a course of time? And, and where do they go? Where do they come from? Where do they go to? That would be interesting if we had over a few years to be able to take a look to see if there's any patterns change. I don't know, have that data in the first place, right?
Yeah, I'm going to take these questions back to the team at Dale, and we'll see what we do have or what we can get.
Right.
And be able and follow up.
You can tell that we're interested in data.
It's good. It's good. They're all great questions.
So Jamie, we'll go back to you.
Okay.
This is I'm seeing traveler ratio, so that looks like a pretty important and expensive item.
Yes. Yes. So the next slide is employee to contracted traveler ratio and contracted traveler job titles. There's a range of dependency on travelers. We have anywhere from 0, which the Mayo as of this time had 0.14%, to 70.76%. We do have 11 out of the 33 facilities that use over 40% of the traveler share. And out of those, 5 of the facilities, the contract travelers exceed the permanent nursing staff. We're also seeing that it's not just in one category. We have 22 out of the 33 facilities are getting travelers for RN, LPN, and nurse aides. So across all 3 levels. And then after that, we do have 10 facilities that are just using LPN and nurse aides and not the RN.
Wow. And I'm looking at the top two are located in Barry and Berlin. So that's, I don't know if that means anything at all, but has this been coming down a bit? I know this is a hugely expensive cost to have travelers.
Yes, we have seen, specifically in doing the EFR, we have seen some facilities have been able to come down, but not all of them. There are still some that have a high ratio of travelers.
And it just seems to me, and I'm no expert on this, but it just seems to me that if we raise the salaries of the people who work there, there'd be fewer openings where we would be forced to pay travelers who cost 3 times as much as the people who are paid to work there. I mean, do we look at that sort of stuff?
I know, I will defer to Angela because I know Dale has done more research and talking to the facilities about that.
What are you finding, Angela?
Yeah, we've been meeting with facilities on this topic, going to them and talking to folks individually and talking about this as a group. It's really multifactorial in terms of why people choose to take a permanent position at a nursing home versus a traveler position. Some people, it's really about where they're at in life, young, starting out or later, versus wanting to have the stability of a permanent position. It's certainly related to wages, but it's all, housing, the region, the particular environment in that nursing home as well, and what other incentives are put in place at that nursing home to hire permanent staff can really make a difference as well. How much focus there is on retention of staff, not just recruitment of staff. So a number of the pilot projects using the LNA grants that were the funding that was appropriated last year are really trying to test different strategies on this to see what really sticks to keep people there permanently versus becoming a traveler.
So will we have some data on that next year, perhaps?
We should have more data to share next year.
Okay, that would be great. I saw Wayne and then Lynn.
Yeah, this was it 4 or 5 years ago when we started with the forgivable loans or different programs for nursing that we were starting to fund. So it'd be interesting to know whether or not that has any impact, or whether the magnitude of what we did was enough to begin to address the problem. If not, then what portion did we actually address, and what actually would have to happen in order to get that done? That is assuming that there are other factors, like they just don't want to work in those spots, that could interfere with our best laid plans.
Correct. And so hopefully we'll have more data from these projects next year and be able to build on them through the Rural Health Transformation Grant as well, because there is an LNA focus there in that funding.
Yeah, my understanding is one of the bottlenecks for creating nursing positions or getting people who go into nursing is that there aren't enough people who are nurses with master's degrees who can go and teach, and the nursing schools or the places that try to train nurses are limited in how many they can accept in order to go and produce enough nurses. And because the problem is that out in the field, you can make a lot more money. You don't need a master's. You just can go out and make money, whether you're a traveler or just they're making serious money at this point. It's a regular nurse in a hospital, just not a traveler, just a regular experienced nurse. And that's the real bottleneck for creating more nurses who are trained and able to work.
Yes, I think for nursing homes, that's particularly a challenge for LPNs. There are only a certain number of slots, there are waiting lists, and it's partly due to the fact that we don't have enough educators, that enough that there aren't teachers for the LPN classes. It's not my area of expertise, but I do understand that is something I have heard. We have heard as well.
Dave?
Jamie, I'm curious if, from where you sit in your experience, if you believe the concept of the base year reimbursement exacerbates and complicates the operation of the nursing home. And I'm going to give you, the committee an example, and you can correct me if I'm wrong. The nursing homes, there are different categories of reimbursement. There's administrative, charges, there's direct care, there's indirect care, et cetera. So as you might think, administrative is reimbursed at the lowest rate. I think it's just the median. So there's 33 nursing homes and the median is per patient day of, I'm just picking $20 per patient day. If you're over that $20, which is half the industry, right? It's the median. You don't get paid that. So you lose it. So it forces you to be very efficient on your administrative costs. But same thing, I don't know what the current cap is on nursing care, Jamie, if any. Can you tell me what that is?
Yeah, it's the 95th percentile for nursing.
High. So it's higher, used to be like 130%. It's come down over the years. So if if I have a lot of contracted staff and I'm paying a much higher rate, it would seem likely that I might blow past that 95% rate. And I would be caught with stranded costs, but not paid for them. And I might have to knock on somebody's door for extraordinary financial relief. But the state, is it every 3 years that we rebase nursing costs? 2 years?
Every two.
Every 2 years. So the state does take a look at it and rebases, like a real estate, they rebase and say, okay, at facility ABC, here's what the cost is, and here's what we're going to pay. You live with that base for 2 years though. It could be good, meaning your costs were below 95%, and you're gonna get them all, or it could be a challenge if you were over. And you're stuck with it. It's very hard to get out of that. Imagine if you were an efficient, low-cost facility and you drove your costs down and you rebase, that's your new rate in administrative and housekeeping, all across the situation. And it's very hard for you to get more reimbursement because the inflation, we as a committee might recall, nursing homes were one of the few areas it's in state law that they get an inflation increase. The inflation increase may be on a low rate, and it doesn't allow you to be competitive to hire the nurses that are getting paid a higher rate at the hospital. So Jamie, I'm just going into this and I hope I'm not too confusing. From where you sit, should we be changing that base year concept or does it work?
So that is actually something that came up in the December report we had to submit on EFR. Some ideas that could help with nursing homes in EFR and rebasing nursing sooner, doing it annually was actually one area that we found, because what happened was in the nursing homes fiscal year 23, their nursing rate was based off their 21 cost. But in 23, they had a large spike in traveling nurses. So we were not paying anywhere near what they were paying out. So that is why we saw a large spike in EFR. And July 1st of 2025 was when we finally rebased nursing to the fiscal year 23 cost. And we are seeing currently less requests. Now, we don't know, more could come in. It's not quite at the end of the state fiscal year, but as of right now, we're seeing less requests. So I do think the timing of the rebase and also the current nature of the facilities with traveling nurses has created issues with the current rebase schedule on nursing.
Just a quick follow-up.
Go ahead.
Have this conversation, have you discussed this with our Human Services Committee? The policy committee of jurisdiction? Or is anybody?
This is the one that we submitted a December report to regarding what we think would help nursing homes, and it is included in that report in detail, and we did bring it up quickly during testimony.
Okay, Because
We can find it on their.
we would want our policy committee to give us a recommendation.
Right,
Right,
Yeah.
thank you.
yeah, but if we want to read the report, we can go to.
Well, that's harder now, that, no. Read them.
Maybe the report that we have. Okay. Okay, anything else on that page? Or do you want to tell us about the EFR on the next page?
Yeah, so this tab is showing the number of skilled nurse facilities requesting EFR. And I'm going to go through this a little bit because the numbers, this is the number of requests we received, but it's not necessarily the best numbers to go off of. So to start, state fiscal year 22, we did receive 5 EFR requests and all 5 were granted. In 23, this is where we see the jump. We had 12 requests. One of them was actually considered incomplete. So we really had 11 complete submissions. And then fiscal year 24 has 20 requests. However, 8 of them were withdrawn and resubmitted, and then 1 was incomplete. So really we had, again, 11 complete submissions. So it stayed pretty similar to state fiscal year 23, which for there we granted 8 of those requests and 3 of them were denied. And then in state fiscal year 25, we had 9 requests, 3 were incomplete. So really we had 6 complete submissions, of which we granted 6 of them. And then I figured it might be helpful now, up to date right now for state fiscal year 26, we have 4 requests that were submitted. 1 was considered incomplete. So we have 3 complete submissions, 1 was denied, and 2 are currently pending.
So 2 are pending and likely to be funded.
At this moment, yes.
So why was there such a huge jump in 23 and 24, and why is it less now? What happened?
So it looks like a huge jump in 23, 24, but if we look at the actual complete submissions, it stayed 11 in 23 and 11 in 24. So the real big jump was from 22 to 23. And that is when the nursing rate was reimbursing at the fiscal year 2021 cost, but they were paying contract nursing in fiscal year 23. And we believe that the drop is because we just rebased to the 23 nursing cost. So therefore, they're finally getting in their reimbursement the higher nursing rate because of what they've been paying. So we believe that's why there's been less requests coming in.
So I get that but the fact is that 12 organizations and 20 organizations applied. Even if they withdrew and they were incomplete, I think you have to count them because they thought they had a need. And so that matters too, even if they didn't complete the application. And if 8 withdrew, why would the 8 withdraw? What were some of the reasons for them withdrawing? That seems like a lot to withdraw.
Those were all the Genesis facilities. So they submitted and then they withdrew because they weren't sure if they wanted to go through with it. And then they actually submitted. I'll have to look. I don't have it on my head, but a lot of them came back for EFR again at a later date.
And so, yeah, so what is really causing this? It has to do with rates. I mean, what's really happening here? These are for profit, so.
I think the workforce is the primary driver. As you know, as we were saying, we were paying at a lower rate. And primarily that is going towards the staffing, right? And we were paying less than what it costs to pay their staff in the 2023-24 time period. It was just this July that we increased those rates based on the higher costs of the workforce.
John and then Wayne.
Can you, thanks so much for being here today. Can you give just a basic example, not to divulge what different nursing facilities are paying the people here necessarily here, but what's the range of rates that you're paying here for LPNs versus RNs?
Wages, you're asking about
Wages,
wages to people.
Just on average, rough estimate, that's all.
That's something that Jamie and her team look at when they're reviewing nursing homes. So I'll see if she
So
wants.
Jamie, maybe do you have just an example of that, what the range might be for LPNs here versus RNs? You know, they have different levels of knowledge, skills, and abilities in each one of those levels of nursing. And we have programs that start off with
Right.
folks entering nursing school to become LPNs and continue on to become RNs, or they are very happy with being an LPN,
Right.
maybe delayed becoming RN later on.
So I don't have that in, an example with me. I can get that for you because we do collect that data, so I will be able to provide that.
I'm just
I will-
curious about that. It's helpful, I think, because I mean, you know, what nurses were paying, what a lot of different healthcare facilities, if it's nursing homes or hospitals, we're paying a much higher amount here for traveling nurses because that was the demand at that time, and that's changed somewhat since then, since COVID. You know, a lot of hospitals don't pay those extraordinary rates any longer. They've offered,
Right.
you know, here's we're paying you else, and we just want to keep you. We want you to stay with us and not travel anymore. So, great. Thank you.
Wayne?
So how often does the rebasing happen? Because it looks like if the base is too low, then you drive them to put in the FR. So the question is, what's the base period, and is it appropriate, or it should be quicker, more reflective of current practice?
Right, right. So the nursing costs for LNA, LPN, and RN are rebased every 2 years. All the costs for all categories are rebased every 4 years, right? So one of the recommendations in the report to address the need for EFR was to rebase more frequently, to rebase nursing every year and other costs every 2 years. To be more, to address, be more, you know, real around what the costs are and be able to have rates according to that.
I don't know if you're gonna say the same thing I was gonna say. Go ahead.
No,
You go.
Well, I'm just wondering, where in the system do we do that? Do we rebase like primary care versus, you know, mental health, the DAs and you know, I just am wondering kind of how that fits into the system of care, that practice.
Who else gets rebased?
So we don't do that with any of our home and community-based services. I don't know, I don't know if that happens for hospitals or primary care services through DIVA.
And we don't do the designated agencies and special service agencies. It only seems to be nursing homes. And maybe you guys aren't the ones to answer that, but I mean, I have to ask why. I mean, the Reach Up stuff, they're using housing costs from 2001. I mean, and you're complaining, you know, you aren't, but you know, they're saying they can't do anything because it's 3 years old or 4 years old. The inequity just is astounding to me.
So this, I mean, we need a historian here because the nursing home the statute has required this, you know, the rules have required this for many years.
Yeah.
I mean, I assume it's because the recognition that nursing homes, we need to have viable, you know, sustainable nursing homes for long-term care.
Yeah, and one could make the argument that we need the entire system of care. And I know this isn't your fault. I just want to raise this as an issue that we are selective in what we have chosen to fund more appropriately than others. Lynn?
I'm gonna ask Dave a question, maybe you remember. But my understanding is that the bed rates for nursing homes, I don't know if that's similar to this, but they were instituted years and years and years ago. Maybe way back before we had the POC, or even maybe just the data,
Mid-80s,
yeah.
around 84, the state language went in to create.
To create that, and the hospitals didn't have that, and before, at that point, primary care, and it was all independent.
Yeah.
You know, there was a few minor positions in hospitals that were employed, and the DAs were just sort of just wandering along, just, I don't know, even state. So it goes back a long, long way.
If I may, the nursing homes went to court. There was something nationally called the Boren, B-O-R-N, was very boring, no, but the Boren Amendment. Congressman Boren tried to depress nationally nursing home spending The language was written in such a way, say you're gonna pay for an efficient facility. The courts interpreted that and all but resulted in the rebasing and the paying based on acuity.
Yeah,
It used to be a flat rate if we were all nursing home patients.
yeah,
And, you know, the nursing home would get paid the same amount for each of us. So they would really look, you want to take a lighter care patient, right? Because you get, the incentive was off. That shifted in the eighties also. But it also came down to, I say, great lobbying in the state to try to portray this story. But it went way back into the eighties.
Maybe earlier than that.
Was the history.
yeah.
And the state, whenever, you know, Senator Jim Letty from Chittenden County, many have attempted to bring the nursing home standard of reimbursement
Yeah.
to other cost categories,
Right,
and many have been unsuccessful.
yeah. And the cost
Cost,
is
yes.
the thing, but it,
But the underlying equity issue and the
Right.
quality challenges sometimes don't go away.
right,
And as we're seeing in the nursing homes, we're gonna pay one way or the other. And it'd be much smarter not to do the EFR, because usually at that point you have to demonstrate that your vendors, you're 90 days late, you know, it's a very, very bad situation. You're
Yeah.
teetering on the edge.
sure.
Better to, I admit I hadn't read the report, I should have, but better to up the rebasing rate, things like that would
Yeah.
go a long ways.
We spent, what, $35 million over the last couple of years, 2 or 3 years on
Go on.
EFR, which is a lot of money to spend when we have so many needs, and this is just one of them.
But COVID exacerbated the whole situation.
Yes.
That spiked the contracted care.
It exacerbated a lot of things. One of the things I'm wondering, again, I'm thinking of this for-profit. I'm wondering how much you look into who owns the property and leases back to the company, and whether it's the same company that's basically leasing back to itself and they're charging high rates so that they can make their money on the leases.
Yes,
Amy, I'm gonna let you.
yeah,
Back
We
to you,
do.
Jamie.
we do look at that. I mean, we look at that not just in the EFR, but in our regular rate setting process.
Uh-huh.
We have specifically in our rule that if we find that they also own the property, we're not going to pay the rent that they're charging them. We're going to pay it as if they own to the property. So we
Good.
do take a look at that. We don't pay them the full amount that they're charging themselves.
Okay, so you can figure out what a more appropriate rate would be, because I can see that's a very nice little moneymaker.
Yes.
While you're
there-
asking for taxpayer dollars to help fund your other operation.
Exactly. And we do, again, look at that in the EFR side of things. The EFR is a very detailed audit that we do where we dig into all their financials they provide. So yes, we do take that into consideration.
Great, okay, thank you.
Yep, absolutely.
All right, where are we? Go ahead.
So we have the next tabs 7 through 9, and these tabs are the EFR for each fiscal year 23, 24, and 25. The difference with this one is these are the EFRs that were where the facilities received them. So the numbers don't quite match up with tab 6 because those were the number of facilities requested, and these are the number of facilities received. But in here, we talk about the facility name, the type of control of the facility, the amount they received, the reason the EFR was requested, and the reason the EFR was awarded. I do want to say, if you dig into this for the reason the EFR was requested, there are some areas that we do not approve EFR for: high management costs, the home office. We dig into that and we don't allow that. Owner distributions is another. We look at
Good.
that, see if they, distributed, and then, So we do really dig into where their money went.
It's,
Well, I mean, so something like Valley Vista, that would be under the Department of Health, and that there was, I'm assuming that this is the same EFR money. or maybe this is different. It's, okay, so that was really for, community health centers and, the Valley Vistas and et cetera, and this.
Provider
Provider stabilization.
stabilization, yes.
Who does that? That's Department of Health?
Department of Vermont Health Access.
Oh, do you?
And is the
Okay.
provider stabilization grants.
Okay.
Okay, Wayne?
So EFRs, these are grants. How's this money flow? How does it flow from here to there?
Jamie, do you want to speak to how the money flows from an EFR to a facility?
Yeah, so when we look at EFR, we determine the amount of money that the facility would need to survive. And from there, we would determine how to get it to the provider. So a lot of times we might put in an add-on or an adjustment to their rate. So that's usually how they get it. It gets put into the rate.
So it's not money appropriated that's flowing through the agency to them.
No, it wouldn't be through a separate
Medicaid.
grant. It would be, they'd bill their Medicaid, they'd bill for Medicaid and it would be added on to the rate that they receive for a certain time period.
Rather than paying out $1 million.
Exactly.
Yep.
So it's paid out to them over time.
Even to cover costs that relate to construction or, because I'm just looking at the descriptions here.
Not sure.
I'm trying to think. I don't know if we've had costs related to construction. Usually we do have a rate adjustment option for stuff like that we would probably refer them to rather than the EFR process. But I do know one area was a flood that happened, and we did look into that one as well. But most of the time, majority of the EFRs have been related to the nursing cost increase and it not being affected in the rate, and then the cost caps as well.
So I'm still confused. Is this, so it's not state dollars? It's not federal dollars? It's private money that's coming in?
It's Medicaid dollars,
Medicaid dollars, federal dollars?
state and federal.
State and federal, because
Together, right?
there's a match. So some of it's general fund and some of it's federal.
Yes.
That's involved. So you're seeing some themes mostly related to labor costs,
Correct.
what I'm saying, is what I'm hearing. Okay.
Yeah.
So that looks like that report, and then we have this other report. Is that sort of saying the same thing, but more in reporty language? That's a technical term.
Are you talking about the December 15th
Yes.
report?
You want to tell us about that?
Jamie, do you want to talk about the strategies identified in the EFR report from December?
I can absolutely do that. So within this report, again, I was looking at the EFR and what are some areas that we could, as a state, possibly change to help nursing homes not need EFR. So we do have two things that are underway that we don't need any policy change or anything like that. And that is, one is providing training to nursing homes on special rates, just because this is an option that we already have in the rule. Some homes we are hearing either don't know how to go through the special rate process, others are saying it's too complicated. So the plan is to talk to the providers and understand what the concerns are there and see if there's anything that we can do to help or at least educate them on for that area. The other one is around PDPM, which is patient-driven payment model, which is the new acuity scores that we use. We used to use RUG-4. We've recently switched to PDPM. That is used in our nursing rate. And the difference with this is the RUG-4s were previously reported by the facilities to the state. The PDPM, we have a contractor who actually gets the scores directly from CMS. So the plan here is to do validation audits to make sure that the nursing homes are coding correctly, and to also have an education period to teach the nursing homes if they're having issues with coding on how it should be coded properly in the system. And then the more intensive changes would be a more frequent rebase. So as Angela stated, doing nursing every year and changing the rest every 2 years. There was another thought too of we're currently 2 years behind, is the potential of maybe bumping up and only being 1 year behind, setting interim rates, and then when we're done auditing, we revise the rates. Another area is the cost caps. We're seeing issues among the peer groups. So the smaller facilities are the ones who are getting hit in indirect and resident care more often. And that is why some of them have come in for EFR as well. They state the cost caps. So more looking at them on a peer group in different settings of, you know, any facility under 40 beds and keep going by that and deciding what the proper cap should be for each grouping. And then the last one would be the step up process. We have seen a big change in the sale of facilities. So the step up process is a way for us to increase the property rate when sold, when they've gone through a transfer of ownership. The rules currently state that they need to be owned for 12 years. And then when they're sold, then we can step them up. What we're seeing is that facilities are selling sooner than 12 years. So what's happening is the basis of their property is now much older than where it should be because they've all been sold like 5 years, 6 years, and so on. The other area too is we look at the CPI and the construction cost index, and the consumer price index is always lower than the construction price index. So that's another area we want to look at because we feel that using the CPI is not helping the providers get a reasonable estimate or reasonable rate for their property.
So Jamie, on the step up process, are you recommending, I see that you recommend changing it, but did you recommend changing it to a fewer number of years, or there's an automatic step up when, or how are you thinking about that?
I'm thinking more so fewer number of years.
Okay.
I would have to dig in more to figure out what the right number would be, but yes, I believe a fewer number of years would make sense.
Okay. Yeah, Wayne?
So the data reporting, the data that you're relying on to do that, you know, a lot of times is things come in later than, it's not real time. So what's the actual lag in the occurrence of something and it being reported so that you have data?
Are you talking about like setting the rates, what the lag is between when we actually get their information and when we set the rates?
What I'm saying, the information that you're relying on to set the base, the data that comes in for that, what period of time is, it's not obviously not real time, I would assume. So is it a month, 6 months, a year, 2 years lag before you can get that data? Because that when you get that data, you can't start making decisions till you get the data in hand. So I'm just trying to get some handle on, you know, what's the general time period within which you have that data so that you could set the base, because obviously you can't set the base beyond the data.
Correct. Yes. So we do have a lag in the data. We receive, I'm trying to think, it's roughly, the lag is 2 years when we set the rate, but we do get the information sooner. It's just we tend to have a lot of providers who request extensions. So we could do it within a year frame if providers provided the information timely. Now, if they have extensions, that's beyond our control being able to set it. Yes, you're correct.
Lynn?
Yeah, can, in the step up, my understanding that you say if they've owned it for 12 years and they sell it, then they can go get a step back. Step up is an increase in their Medicaid rates. Is that correct? So the new buyer, the new owner will get an increase in what they receive. Is there a time limit on that, number one? And number two, have you examined why they're doing it sooner than the 12 years and selling it? Is that they're losing money and rather than try to get involved emergency reimbursement and all that kind of stuff. They're just selling it. And then what does that do to the new buyer?
Yeah, so we are seeing a trend of them selling it much sooner than the 12 years. I know there's various reasons why they're selling. A lot of it, I believe, does have to do with the financial stability of the homes. What we find is that finding a buyer for a facility when their property rate will not be stepped up is harder to do, and it's not helping buyers want to buy the facility if their basis is going to be based on 2004 or whatever. So they're getting stuck way back when the reality is they're buying it now and it's, the price has increased significantly. So it is harder to find buyers who are willing to take that on. So that's why rate setting thought is if we could lower the 12 years to a smaller number of years, it might open up the door more for other buyers to want to partake if their step up could take place.
Is there a limit on the amount of time that step up exists, or do they revert back to another rate, or how does that work when you're the new buyer?
Can you
Is that
repeat that
one?
again?
If the step up goes from one rate up higher to the new buyer, does that go on indefinitely, or is there a time frame in which you allow that step up and then it stops?
No, so the step up, the way we do the step up is everything we do is based off depreciation, financing, amortization. So we're not just paying the cost of the facility, but we pay it over, 30 years. We use the useful life for each asset and figure out what each asset's useful life would be, and then do it over certain years. So the smaller assets could be more like 10 years, but then the building could be 30 years. And then that would stay in place until they were to sell it after owning it. Right now, for the 12 years, then we would do it again.
Okay, thank you. Dave?
Amy, if I bought a facility with a low step up, but I went later and refinanced it for a higher rate, would I create a new step up that way?
No, we would need a transfer of ownership to occur.
Okay, thank you.
Yep.
You can tell we're not on the Human Services Committee, except for Dave, who knows all this stuff because he's been there. Wayne?
Yeah, back on the base again and the reporting from the providers. It behooves them to get the data in so that you are able to, or especially if you revise the timing of when you can redo the base, behooves them to get it in. Is there any federal payment? What's the holdup there? Is it just administratively they're not doing it, or is there something in terms of the actions of the feds in terms of Medicaid that would cause a problem?
A lot of the extensions tend to be due to having to get audited financial statements because we require each nursing home to be audited by an independent auditor. So that tends to be part of the reason.
Thanks.
Yep.
Can I add one thing?
Please.
Just, all these different recommendations and strategies that Jamie just talked through, we're talking with nursing homes about these ideas as well as part of our engagement process for stabilization and sustainability, and hoping to see what they have for input in terms of what might make the best impact as we move forward with our strategic planning.
The goal would be to eliminate EFR. We hope, or
At least
minimize.
lower it
Yes.
significantly. That is a major goal.
Right, and I think we have 2 million in the budget this year. Or is that for provider
Provider
stabilization?
stabilization.
Never mind, the other one.
In BAA, there was 14
Right,
million.
14 million.
BAA.
And that's usually where it happens. It doesn't
Right.
happen. You don't put it in the budget.
Right.
But we will hope, in the year before it was 21, I believe.
Yes, so it's gone down and we're certainly hoping it will.
Given where we are with revenue, and I would hope that it will be a whole lot less than 14 million ex BAA. Yeah, Marty.
So this report was required by last year's budget, and obviously you produced it. And you're now talking to the nursing homes about what you might do and what your ideas are and theirs are. So is the thought to have some legislative fixes suggested for next year? So that we might be able to make some of these changes? Or do they require legislative changes? Are these just rule changes that?
Some of them are rule changes, I believe, right? And in terms of the frequency of rebasing and the change in the step up process and cost caps, those are all in rules, right, Jamie? I should be looking there.
Right.
Yeah. So that would be the agency having to go to the rules committee and suggest changes in rules.
Right, but there would likely be a budget impact and a request for funding to support those changes.
In next year's budget.
Right, 28, yep.
In order to get to a solution.
Right. Yeah. Any other questions for these folks? Anything else you guys would like to educate us on before we let you go?
No, we really do appreciate the interest in this topic and all of the good questions because it's complicated and we really want to support the sustainability of the system for all of Vermont, all Vermonters. So we're digging in. We appreciate that you're digging in with us.
Well, we appreciate you coming again. I know you were in Human Services last week and it's helpful for us to be educated too. The more we all know, the better we can make good decisions.
Better than human service.
For questions, yes, they have a different kind of expertise and focus. Thank you both very much. I appreciate it.
You're welcome. And we'll follow up with.
Okay, with all of our crazy questions. Great.
Thank you.
So committee, let's see, we are busy in the morning. We start with, we're just gonna come to the committee room in the morning.
Yeah, we're going to David, she's in the lobby at 9:30.
9:30, okay, so no carpooling necessary, just show up. We'll leave at 9:30. And then after the floor, we'll take up the salt bill S218, so you can take a look at that. And that's